Hello, I'm Ola Landgren. I'm head of the Myeloma service at the Memorial Sloan-Kettering Cancer Center in New York City. I'm here at the ASH meeting in San Francisco presenting on our results on the study using Carfilzomib, Lenalidomide and Dexamethasone in high-risk smoldering multiple myeloma, the final results from a phase 2 trial at the NCI. The objective of the study was to look for response, and we used the clinical criteria that we typically use in multiple myeloma. The population of patients in this study was patients with high-risk smoldering multiple myeloma, and we used both the Mayo Clinic and the Spanish PETHEMA criteria. So patients who had high-risk smoldering multiple myeloma by either of these two criteria were deemed to be eligible, including additional eligibility standard criteria as well. We used a combination therapy with Carfilzomib given at dose 20 milligrams per meter square, the first two doses, followed by 36 milligrams per meter square, all the subsequent doses. And we gave Carfilzomib day 1, 2, 8, 9, 15, 16 on a 4-week schedule. We used Lenalidomide, 25 milligrams, day 1 to 21, also on the 4-week schedule. And Dexamethasone was given 40 milligrams per week, every week, and that was given for 4 cycles. And after 4 cycles, Dexamethasone was decreased to 20 milligrams per week. The entire combination therapy was given for 8 full cycles. After that, patients were put on Lenalidomide extended dosing or maintenance, 10 milligrams, day 1 to 21 on a 4-week schedule for a total of 2 years. The toxicities in the study show similar types of toxicities as we have seen in prior studies where we have used this combination for patients with newly diagnosed multiple myeloma. There were, for example, hematologic toxicities with decreases in counts in some patients, and also there were non-hematologic toxicities that again are typical for this combination of drugs. On the result note, we found all 12 patients in this pilot study to reach a complete response, which of course is very impressive. We also did additional workup with minimal residual disease assays, and we had 2 types of assays. We had both cell-based assays, which were the new or the next generation flow cytometry assays. 11 out of the 12 patients were MRD negative. In addition and in parallel, we used next generation sequencing for the VTJ sequence, and we found 10 out of the 12 patients to be MRD negative. So these are the final results per the study protocol. We are now following patients, and we are also collecting samples over time, both bone marrow aspirates and blood and urine per the protocol. And we are continuing to study the longitudinal minimal residual disease status over time. And the plan is to expand the efforts, and we are now working on a new study with the intent to have a randomization between this therapy and a control arm in a multi-center fashion in the United States, and we hope to open that study in 2015. Overall, I think the results are very encouraging. We show, as I already mentioned, that 12 out of 12 patients reach a complete response, and almost every patient is minimal residual disease negative, and they seem to maintain MRD negativity. Limitations of the study at this point is the small sample size and the current lack of longitudinal data. But I do think that the results are very encouraging, and therefore we have now decided to move ahead and develop a larger randomized follow-up study.